Hi everyone, we are from Group 15, presenting case number 7.
The choice of anti-hyperglycemic agent for her will be metformin. This is because our patient is having several episodes of hypoglycemic attacks, and metformin, which lowers blood glucose by decreasing hepatic glucose production, does not have glycemia as its side effects.
Furthermore, our patient has a good glycemic control with a HbA1c of 6.5%, and there is no non-complications of renal, liver, or cardiovascular problem. Hence, we only advise on a monotherapy of metformin because metformin can reduce HbA1c by about 1.5%, and the cost is low and it can be consumed easily by oral. The adverse effects of metformin is that it will cause nausea, diarrhea, and also anorexia. These adverse effects can be inhibited by taking metformin together or after a meal. It should also be taken as a single daily dose followed by weekly titration. In addition, there is also an extended release formulation to reduce the adverse effect of metformin. In addition, lactic acidosis caused by metformin is very rare and is usually associated with renal impairment. However, there is a complication of long-term metformin therapy which is causing the vitamin B12 deficiency.
Okay, for the dosage of the metformin, I will start on the lowest dose, which is 500 milligrams per day, and depends on the patient condition. I might titrate it up to a higher level, which in the maximum is 1000 milligrams 3 times per day. And if the patient does not show good control or is intolerant to metformin, I will suggest for a change to other anti-hyperglycemic agents such as SGLT2 inhibitors, DPP4 inhibitors, as well as GP1 analogs.
In experiments involving rats, oxidative injury is detected in dendritic region of the hippocampus after recurrent or moderate hypoglycemia episodes. It also causes sparse neuronal death in cortex, and also the significant cognitive impairment detected 6 weeks after hypoglycemia. And it's also more severe seen in diabetic rats than non-diabetic rats. So in conclusion, this study may suggest that recurrent and moderate hypoglycemia is associated with chronic cognitive impairment in diabetic patients.
Hypoglycemia causes a cascade of physiologic effects, presenting several potential mechanisms through which acute and chronic episodes of hypoglycemia may increase cardiovascular risk. Acutely, hypoglycemia stimulates the autonomic system, resulting in a cascade of actions including release of epinephrine and increased gluconeogenesis in the liver to restore blood glucose levels. This stimulation causes an increase of heart rate, systolic blood pressure, blood flow in the myocardium, and cardiac output, adding stress to the cardiovascular system at least temporarily.
So hypoglycemia is when your blood glucose level is below than 4 millimole per liter. And patient might experience autonomic symptoms such as anxiety, palpitations, sweating, and tremors, and can be worsened by having neuroglycopenic symptoms such as irritability, blurring of vision, difficulty of speech, dizziness, drowsiness, and loss of consciousness. Over time, repeated episodes of hypoglycemia can lead to hypoglycemia unawareness. It is when your brain and your body no longer produce signs and symptoms that warn that you are having hypoglycemia. And when this happens, the risk of severe life-threatening hypoglycemia is increased.